I'll say that again. Eric Shortmiller, our guest today, who's volunteering his time and to share his expertise, is a PT at Physical Therapy and Balance Center here in Bellingham over in the Barclay neighborhood. He is a wealth of knowledge. And I think, Cynthia, you were the one that asked for this talk. And so, yay, you're here. And we'll just turn it over to Eric to learn about sciatica.
Well, great. I appreciate the opportunity to share again. You know, I often think about one of the things that I love about my job is this opportunity to just talk with people about different aspects of whatever problem they come in the door with. And the education piece is just one of my favorite components of that. So I appreciate the Y taking an opportunity to let me just share a little bit of what I know with you guys. And what I'm going to do today is provide you with a couple of baseline things. Some of you who have experienced back pain or sciatic type pain can relate to a lot of this. And then I'm going to talk about sort of the causes and some of the things we can do to prevent it, but then also maybe some ideas of what you can do to try and help treat it so that it doesn't become as problematic for you. And then we'll also, you know, as we go, we can have some question and answers, and I might be able to explain some stuff too, or I won't make up anything. And if I don't know the answer, I'll tell you I don't know, but I'll try to avoid that temptation to just make up stuff. So I'm going to do a screen share here for the first little part, and then I'll jump back in, and then we'll do some more so that you can see different slides as we go, because I found some interesting pictures that might help explain things. And then I'll use my buddy over here too to kind of help explain some stuff. So let me click screen share here. All right. And we're going to start the slideshow from the beginning here. And so this is, of course, is everybody seeing that? Give me a thumbs up if you see it okay. There you go. Great. So that, of course, is me with less gray in my beard. So I probably should get a new picture there. But Tammy did a great job of introducing me, so I don't need to talk much about that. But a couple of things, stats here include the fact that, you know, within America, 80% of us are going to have some low back pain at some point during our lives. And for some of that, it is just related right to the low back, but for maybe 13 to 40%, according to the British Journal of Medicine, some of those will include episodes of sciatica or referred pain. And so just thinking about what that is, you know, the definition of that is pain that travels along the path of the sciatic nerve. We often use the term peripheralized or works its way down. And it might be anywhere that whole sciatic nerve travels. And so I have a couple slides here that we can talk about that because every good physical therapy class starts with anatomy. And so I'm going to load you up a little bit with some anatomy, but we'll try not to make it too boring for you. But I love anatomy. So what we're looking at in this picture is the backside of a person who has the distal or terminating spinal cord there in the center of the screen. And then what branches off of that spinal cord are the nerve roots. And you can see on the right-hand side of that screen how those nerve roots sort of clump together and form a lumbar plexus, we call it, that eventually leads to something called the sciatic nerve. Now that sciatic nerve, if you take a look at your pinky finger, that's about the size of your sciatic nerve. So it is a big monster. And the benefit of that nerve is that it does a couple of things. One is that it carries motor impulses from your brain to the entire lower extremity. And that That's what makes your hamstrings contract when you're laying down and doing a hamstring curl. That's what allows you to come up on your toes if you're trying to reach into a cupboard, because your brain says, I got to get that glass out of there. So you raise up on your toes, and that travels from your brain down the spinal cord, through the sciatic nerve, down to the calf. And that's how you generate power out of your muscles. So you've got this big, thick sciatic nerve, and it doesn't stay the size of your pinky all the way down. As it travels out of the buttock and down between the hamstrings, it starts to branch off, and it starts to change names, just like many of our roads in Bellingham change names once they curve a little bit. So you've got the sciatic nerve as the big guy right up there near the buttock. And then as it starts to feed different muscles on its journey, you can see that it'll feed the lower extremity, primarily the musculature on the backside of the lower extremity. So that's why people can feel symptoms in a variety of places, whether it's in the buttock, sometimes to the knee, sometimes below the knee, sometimes on the outside of the leg, sometimes outside of the foot. So it'll have a pathway that produces pain in a number of areas. The picture to the right there shows the cutaneous intervention, which means the area of the skin that is fed by those different nerves. And so that, again, kind of just demonstrates in Netter's anatomy book here where people could feel stuff that generates from that one nerve. That big old nerve, like I said, comes out of the lumbar spine. So as I take my spine here, what we have is you're looking at yourself from the side here. So your pelvis is here, your hips right there. On the back side, we've got your sacrum. You got your green lumbar spine, but not in real life. And then your thoracic spine here. And of course, moving up, you got this little inward curve of the cervical spine, and then your skull sits right up here. So what this model helps to do is it allows us to kind of explain the way things work. So in particular, as we're thinking about that lumbar spine, we're thinking about these lower segments of the lumbar spine. These are your vertebral bodies, and these things in between are your discs. And so the disc helps to provide some shock absorption, some cushioning. It also helps to create a spacer so that your nerve root, this little yellow guy right here, that nerve root has a space to come out from the spinal cord, or that cauda equina, that distal part of the spinal cord. So this is a nerve root, this is a nerve root, and these lower nerve roots, along with some of them that come out from the sacrum here, that's what clumps together to form that big old sciatic nerve that comes out right where my finger is in this notch. Now envision, if we took away your skin, you would have a big muscle called the gluteus maximus. And that's why it's maximus, it's a big guy. But if you got rid of maximus, then you have gluteus medius. And if you get rid of that, you got gluteus minimus that sits under here too. These all attach to your hip joint. And then you have piriformis, and you have some other muscles that help to rotate your hip in and out. So we call it the rotator cuff of the hip. So this big hole where that sciatic nerve comes out, just like my finger does here, it sits right below the piriformis muscle. So you might hear people talk about piriformis syndrome and some other issues. And so if that muscle's tight, that could influence things that are going on there as well. So there's your brief 3-minute anatomy lesson. You have lumbar vertebral bodies, you have discs. They allow for the spine to move and absorb impact forces, and they provide space so that the nerve roots can come out. So we'll get this guy hanging back up again. And I'll go back to sharing some pictures here for just a minute. Okay. So let's go on to the next slide, maybe. Symptoms. So what people might feel, like I said before, you might feel pain in your lumbar spine when it starts to travel into the buttock area and down the leg. It could be pain that follows that pathway, but other people might feel symptomology that it could include weakness, because remember that big sciatic nerve helps to provide power to the muscles. So if something's impinging the nerve, you could end up with some weakness in your lower extremity. The nerve also carries messages back to the brain, sensory input. When we talked about balance a number of years ago, we talked about how the somatosensory system carries information about where you're at in space back up to the head. So there's a two-way path on that nerve. And so you might get sensory changes as well. You might find numbness. You might find burning. You might find electrical jolts, which is not comfortable. So there's a whole variety of symptoms that people might experience when they're feeling sciatica type symptomology. And again, some pain is enough. You don't have to have more, but it could be pain and it could be some other things that are going on there. The numbness, the tingling, the pins, the needles, that's typically neural type pain. And then if we start to see motor weakness, that also can happen in real severe cases. So mild sciatica usually goes away over time. When we look at the studies, most of the time it's about a 3-week to 3-month course of symptoms, and they gradually improve over those periods of times with minimal intervention, or like not surgical intervention. So typically the course on a mild sciatica will resolve over time. Again, sometimes we need to have more aggressive intervention, including physical therapy, sometimes injections of a corticosteroid, sometimes surgery. So the course usually resolves, but not always. When are you going to see a doctor? I would say that if you're finding no response from self-care, if you're a person who takes some anti-inflammatories, or if you're a person who has had a history and you've done your sort of homework and tried to do things again like you did in the past, and it's not changing, or you have severe symptoms that are progressively getting worse, you got to go see a doctor. Now, when you're coming into my office, I have some red flag questions that I also like to check out. And, if you need to seek immediate care, if this is a sudden severe pain in the low back or the leg, or weakness in the leg, where it just suddenly you're dragging your foot, or your knees buckling on you, or those sort of things, you got to seek immediate care on that. If the pain shows up after an injury, usually a car accident, but sometimes a fall. If you start to have a change in your bowel or bladder control, that's another one of my red flags where I'm like, you know what, before we do any therapy here, let's get you in to let's talk to the doctor again, and we need to figure this out. The other one that I often ask patients about is something we call saddle anesthesia. So envision sitting on a horse's saddle, and if you have any numbness anywhere in your perineum where that part of your pelvis sits on a saddle, if any of that's numb, you need to mention that to your doctor, because again, that means it's kind of affecting nerve roots lower down, and it can also be accompanied by the bowel or bladder changes or inability to control those sphincters, those muscles. So that's when you got to see a doctor. So what causes all this? And there's a number of things that can influence it. Thinking back to our spine, the reason why I was pointing out discs is because sometimes a disc can bulge, and that can put pressure on that nerve root that makes the sciatic nerve lower down. So some people don't feel the pain in the back, they'll just feel symptoms in the buttock and the leg. So it could be a disc that might be bulging or herniating. Sometimes the disc breaks loose of its bounds and it sequesters, or it herniates even further out, and that can cause it. Often it can be related to changes within the spine as well. Sometimes we lay down bony changes, we start to lay spurs down. Just the same thing that happens in a knee, where your knuckles as we age, can happen in those joints of the spine. and you start to lay down some arthritic changes, which could include some osteophytes or spurring, that can put pressure on the nerve root. As we move down the spine, we can also see muscle imbalances. Sometimes a really tight hip rotator group, like that piriformis in particular, he gets all the press because he's the biggest one. But if you have a tight piriformis, boy, oh boy, that can just sometimes compress that nerve. In a small percentage of the population, the sciatic nerve actually exits between the muscle fibers. And so if it's a really tight piriformis, it can compress that. Now, that's not in a large percent, 2 to 5%, I think is the latest numbers I've seen on that. But it can be miserable. And so you really got to make sure you have a good flexibility program going for that. We'll talk a little bit about that in a few slides here. So it could be coming from the spine, but it could also be coming lower down out of the buttock itself. Risk factors, just like everything, age can be a risk factor. The longer you're using your tissues, the more they change. So that's hard to control age. It's not something we can control, but it's something that is a factor in that we see this more often as we grow older. Obesity tends to change the loads. We're going to physics now. And so, if you have more of a load on the anterior aspect, if you have a beer belly or more adipose tissue on the front side of you, that's going to pull the spine one direction, and that can change the load. More body mass increases vertical load on that spine, and that can add to squishing those things. So obesity can be a risk factor. Occupations. If you have a job where you have to reach up overhead a lot, you're putting your spine into one position a lot. If you have a job where you're bending and twisting a lot, those things can put you at increased risk. It doesn't mean you're going to have trouble. It doesn't mean you're going to blow a disc. The way we are made is incredible in that nucleus of the disc is surrounded by ligaments called the annulus fibrosus. And those ligaments are so strong and they're laid down in this incredible way that allows for us to twist and move and lift things. So it's not that lifting is bad, but just be aware that a lot of repeated things of any one nature can be problematic. Same with the prolonged sitting. We see this in people who drive for a living. And we also think sometimes as the car moves down the road or the truck moves down the road, there's a certain frequency to that 4 to 5 hertz that is kind of hard on a disc. And so truck drivers, taxi cab drivers, Ubers, Lyfts, people who just love a good long road trip and don't want to get out for 14 hours, that can be rough on you. So those are some of the risk factors, and certainly the office jobs. And those are all things that can be aggravating to a sciatica symptom. So what do we do to prevent it? Exercise. So you guys are already a step ahead of a lot of the population because you're already at the Y, which is just perfect. And then posture, and then body mechanics. So again, thinking about those things that could put you at risk, different occupations, different jobs, we can work on body mechanics. We can work on posture to help unload or change the load on that spine. So how can physical therapy help? Well, a lot of times, if that mild case doesn't resolve on its own, then they might send you to physical therapy. And what we would do is kind of help evaluate what is the pain generator that's leading to this problem that you're having. And then we help develop a plan of care to help you meet your goals. It would probably include instructing you in different home exercises to address any imbalances, whether, oh gosh, this muscle's really tight, this one's really weak. We need to fine tune your strengthening program or your stretching program and have you address this one in particular for the next season, 3 weeks, whatever. So we would help you to develop a home exercise program. Occasionally we need to institute modalities as needed to help you mitigate pain. Things like electrical stimulation, TENS units, other things that we can help just get the pain under control so that you can go back to moving. And of course, we love teaching. So body mechanics is something that we love to work on. I went through, and all of my staff and a number of therapists in the community have gone through different courses from the McKenzie Institute. And so part of what I really appreciate about the McKenzie system is that it gives us a method to look at pain of spinal origin. And if we run you through this evaluation and we find that, wow, symptoms are getting worse, oh, symptoms are changing and improving, we kind of have an idea of what direction to move you. And we call that a preferential direction of movement. So the McKenzie system really works well for figuring out a lot of these pains that come out of the back or that travel down a leg or an upper extremity. So again, trying to decide, is this pain of spinal origin? If it is, then what do we need to do to help alleviate that? It could be that it'll include promoting posture interruption. So that means you're on that road trip and you want to just blow through all the way down to San Francisco, but man, stop, get out, take just a couple minutes to extend every couple hours. You know, it just change the load on the spine. I often tell people, if I took your finger and I pulled it backwards, you know, that'd probably be uncomfortable after a little while. And that's what your spine goes through and your muscles go through and your tendons and your ligaments, is if you hold them in one position for a long period of time, they get tired of that. So I like to have people interrupt their posture when they're having this sciatica type symptomology. And that means if you're a person who stands all the time, you may need to occasionally sit. If you're a person who sits all the time, you need to get up and stand and change those positions, because the spine is made to move. And that's what we got to keep it doing, is keep things moving. When you are sitting for a long duration, you need to sit with some support to help you maintain that inward curve. So the picture here shows a person using a lumbar roll that she has added to her chair, because even though chairs may have some lumbar support, sometimes it's not adequate. And we all have different sizes. So sometimes you need that support to be up a little bit or down a little bit. And that's where that can be really helpful. I often have my patients start with a towel, roll it up, put a little tape around it, and stick that, you know, maybe at the belt line, up, down, move it around, find a place that's comfortable to give you a little support when you're stuck sitting for a long period of time. And then also we try to find the right direction to move you so that we can help change your symptoms. So it's really enjoyable when a person comes in and you start moving in one direction and they describe their symptoms, and their leg is going, well, it was in my foot and now it's in my hamstrings, and you keep moving that direction, and all of a sudden they're going, you know, yeah, it's in my buttock, and wow, you know, now it's just in the low back and it's no longer in my foot. And that is just so exciting to see those rapidly reversing changes. I'll tell you, it doesn't always go that fast, and frequently it doesn't, but it is, we can start seeing changes sometimes when we run you through these movements and go, wow, so that position really aggravates you. Let's go with a different direction and see what the response is on your symptoms. So I have found this McKenzie system to be very beneficial in helping us to figure it out. But again, it doesn't always come from the spine. Sometimes it comes out of the leg and out of the hip. And so, you know, there is a wealth of YouTube videos and resources out there, but I have found that just getting that piriformis in particular, and again, I mentioned earlier, it gets all the press because it's the biggest muscle. But in addition to that piriformis, you have the obturator, and you have the superior and inferior gemellis, and you have the quadratus. You have all this group of muscles that help rotate the hip. And so there's a variety of ways you can stretch to help open that up and to alleviate some of those symptoms. So these are just 3 of them that we'll often try with our patients to stretch that piriformis. If it's tough to lay down on the floor, we have people do it in sitting. And, you know, those 2 sitting postures kind of change the angle of the fibers. The muscle itself is rather pennant shaped, that it looks like a pennant. And so there's fibers that are more vertical and fibers that are more horizontal, and then everything in between. So you might just need to fiddle and find the best stretch that addresses your tightness. If the pain is coming from spinal origin, a lot of times we will work on helping you to find what direction is the best direction to move. And so initially, a lot of people think, oh, the McKenzie system. Yeah, I've heard of that. That just is extension. Well, and that's what the gentleman on the left is doing, is extending that lumbar spine. And that works well. It works really well if it's a disc in a lot of cases that might be bulging and putting pressure on the nerve root. But sometimes it might be stenosis of the spine or a narrowing of that hole where the nerve comes out, in which case, when you bend backwards, that might make the space even less available and you're further pinching the nerve root, making you more miserable. So that's where we have to test and retest and observe what happens with repeated movements. And we start to go, oh, wow, okay, so yeah, initially it felt good, but boy, as we got to number 10, number 12, you got worse. Okay, let's try going the other direction. So for some folks, flexing forward of the lumbar spine opens up those spaces. So that allows them to alleviate the pressure on the nerve root, allowing that inflammation to start dropping and helping them to feel better. So again, these are the things that we test and retest and kind of get a hunch based off your subjective complaints, off of what helps you so far, what doesn't help you, and then we can develop a plan to address that. So let me stop sharing my screen here for a second. There we go. And again, this is where I wanted to kind of take my friend Lurch here again and talk a little bit about that. So if it's a disc that might be bulging and they don't really look this nice and encapsulated, but when that disc starts to bulge out to the side here, it starts to encroach on the space that's available for that nerve root. And then that can put pressure on the nerve and create the symptoms that you're feeling down the leg. So that's where sometimes if that disc is kind of bulging, we start moving it, and just like a water balloon, we're trying to push that disc back to the center. And for some folks, that works like a charm. Now, if your problem was that you had some spurs back here and little bony changes and things that are kind of jabbing in, the further back you go, the further closer this gets and encroaching upon that nerve root, and you start to irritate it. And so for some folks, once I flex, man, I open up that space and that nerve just goes, oh, thank you. Thank you for getting the pressure off of me. So for them, we start them on more of a flexion-oriented program. And again, then we couple it, once we figure out what direction feels best, we start strengthening all the muscles around here, your abs, your back extensors, your transverse abdominis. All these muscles are guy wires that support this big tower of a spine. So, it's not just one direction. It's not just one exercise that usually helps. It's kind of putting together a whole plan of stuff. I'm just going to set Lurch down to figure out what you need and what we can do to help. So, but I think the take-home message is movement is good. Movement is really what you need to keep doing. Interrupt postures where you're stuck in one position for a long period of time. And yeah, get help if you need it. So those are kind of the key things that I'd like you to take away. But yeah, we've got some time. So Tammy, should we open it up to some questions?
That was awesome. I learned a bunch too. And if you have a question for Eric, if you want to put it in the chat box right now, and then we can just do that for a few minutes. And then Eric, I actually have 2 questions right off the top for you. Yeah. One is, I rarely use the back of my chair. I just use my own muscles. And is there a pro or con to that? And the other one is if you could clarify, so most of us have heard about piriformis syndrome. So how do you as a PT tell the difference between the two when you're evaluating someone?
Sure. So there's nothing wrong with using your musculature to hold yourself in a position, but you can be as strong as an ox and gravity is unrelenting. And which is good because it keeps us all in place. But over time, these are muscles that are designed, they're slow twitch muscles, they're designed to help hold you for a long duration. But over time, you might notice if you're working at your desk, all of a sudden you're starting to get engrossed in this, and before you know it, you're like focused because, and it's partly just gravity. So for some folks, we just need to give them that little reminder to help hold them there, just to give them some support for the long haul. But in the short run, I like it. And in fact, I often have people go through exercises where they may be doing, things like slouching and then overcorrecting and then coming back off about 10% so that they can kind of be in that more neutral position where there's just a little inward curve. We don't want you to be hyperextended. We don't want you to be overly flexed. We want you in that sweet spot in the middle. So, there's nothing wrong with using your musculature to help hold you. Just realize an 8-hour day is a long time to try and maintain that, and gravity is going to win always. So thinking about the piriformis syndrome, again, what we'd look for is we look for a limitation in hip rotation, typically, and the hip flexors and the hamstrings, because again, any of those structures that could be tight could influence that sciatic nerve, especially hamstrings, piriformis, IT band. That nerve in the slide kind of travels right between the medial and lateral groups of the hamstring. So if we were going to dissect you after you donated your body to science, we would pull those apart and you would see that big, thick nerve just traveling right down. But, it's really funny because in those anatomy pictures, it looks like these things are all very separate, but realize there's fascia, there's connective tissue. And so if you're tight in some muscles, that could be adhering to some of that nerve. And so we get you going on stretches. A lot of times we know it's more piriformis in orientation when we run you through a variety of lumbar spine tests and we don't provocate it, we don't make anything worse, and we don't make anything better. Then we kind of go, it could be coming from down here. So we base it off palpation, we base it off clinical screens and tests, and then we start working you towards what seems to be most effective in terms of exercise. So we kind of rule out the spine, address the imbalances about the hip, and in particular piriformis and the rotator cuff of the hip.
So you'll be happy to hear we always do a piriformis stretch at the end of our classes, always. So
Perfect.
We have 3 more questions. Do you have time for them?
I sure do.
Okay, number 1. Can you experience sciatica on both sides or only the right side?
It's most common to show up only on one side, but if you're getting symptoms traveling down both legs, it happens. In which case, then I'm often thinking it's not in the hip, it's coming from up here. And most often it's a bulge or something that's pushing straight posteriorly, not usually to one side or the other. And so then I'm usually thinking right away, something spinal versus something lower down that might be the cause of that.
Okay. Number 2, what is the difference or connection between sciatica and SI issues?
Yeah, because they are neighbors. They're, here's your SI joint right here. And I was just saying, and here's where your sciatic nerve comes out, right in this notch. And so that connection is huge, because if you have an SI joint that's very hypermobile, it moves way too much, and they're trying to get you stable and they're trying to brace you, that's just creating a lot of play down in through here. Or if you're stuck or your SI joint's a little twisted, again, the nerves that come out that make your sciatic nerve include L4, L5, and S1, 2, 3. So the correlation there is there. And it could be an SI problem. We tend to try bracing. We tend to try some different techniques manually to see if we can affect that symptom. Again, we have different clinical tests to stress the joint and create some shear. And we try to differentiate that as part of our examination. But there is a connection.
All right. Thank you. How does scoliosis play a role in what you say?
Sure. For a lot of us, most scoliosises include this lateral curve. That's what a scoliosis curve is. For some of us, we have an idiopathic or more of a twist to the spine. And so up here in the thoracic spine, where we see a lot of scoliosis evidenced, we won't see that irritate the nerve root as much in terms of sciatica symptoms. It can certainly irritate these nerve roots of the thoracic spine. In the lumbar spine, the way we're made is we have these joints that are more oriented this way versus obliquely. And so it's tougher to get more rotation out of that, but there is some side bending. So people who have more of a curve in the lumbar spine might be encroaching on the concave side, and on the convex side, it's gapping. So it can affect it. Usually though, it's affecting higher up in that chain of the spine.
Okay, so one more question slipped in. Do you have time for that?
Absolutely.
Great. This isn't me, this is the question though. I have limited hip rotation due to sitting too long. A body worker told me it was most likely due to my psoas muscle. Do exercises for sciatica work for the psoas muscle?
You know, in a sense, yes. The psoas major and minor come off the front part of your lumbar spine. So I kept pointing to this posterior back side of you, but the psoas comes off here, and then it interacts and connects with the iliacus muscle, and you get that iliopsoas that comes down and inserts on this bump of your hip. So it helps, if you can envision the muscle here shortening and contracting, it pulls the hip up. So when we sit, that muscle gets tighter. So a lot of the stretches, like I showed you for the piriformis, will not really affect iliopsoas as much, but certainly the standing extension or the prone extension exercise, like a cobra in yoga, those guys will start to stretch a little bit of that psoas. There's also a lot more effective stretches for psoas major and minor and the iliopsoas in terms of the hip flexor. And so the specific piriformis guys won't get that one as much as the iliopsoas. But where the iliopsoas inserts on the hip, its primary job is hip flexion, but there is a rotational component to it as well. So it's a secondary movement of the iliopsoas versus a primary movement. So to answer the question, exercises for sciatica will help with some of the imbalances, but you probably need to be more specific about that iliopsoas group in particular.
Well, there are no more questions, but there's a comment that I think encapsulates how many of us that are here today feel, which is from Tom Grimstad, I believe, and it says, this presentation was excellent and very helpful to me. Thank you. And I think we all feel the same. So thank you so much for sharing your time and expertise with us today.
Absolutely. It was a pleasure. Like I said, I love coming to talk at the Y, and I look forward to seeing you all again sometime soon.
Well, you know what that
senior
means when you say that, Eric. I'm
fair and yeah.
See you next time.
All right. Thank you guys. Everybody have a great day.
You too. Thank you.
All right. See ya.